Thank you. Thank you, Purvi, for your generous introduction. And it's really great honor for me to talk about this important guideline, which was presented recently in the month of March 2026. And a lot of changes are there, which are very exciting. So let's go deep into it. So this is the cartoon which says that the good news, your cholesterol has stayed the same, but the guidelines have changed because the guidelines have been changing very often. That's because the new data comes in and therefore we keep on changing the guidelines. So the objective of today's discussion is to review the latest update of the lipid guidelines and the clinical implications. We'll see the risk stratification strategies in the cardiovascular risk assessment. We'll define the evidence-based treatment targets across the risk categories and the translate guidelines recommendation to practical clinical decision making. How do you use these guidelines in day-to-day practice is what we're going to see. So this is the guideline which is published by multiple organizations have joined together. To name a few, it is ACC, AHA, ADA, and so on and so forth. More than 21 associations have joined this guideline. It's published on March 26. It replaces the 2018 cholesterol guidelines. In the past, it was called the cholesterol guidelines. Now it's called lipid guidelines because it is much more beyond cholesterol, and therefore we need to update ourselves. It is a very comprehensive update, 120 pages. These are actually the pages and further references beyond that. And the entire shift is towards a risk-based and a goal-directed therapy. So the entire conceptual shift in this guideline that says that LDL is essential but not sufficient. The risk is driven by the atherogenic particle number, which is ApoB. Therefore, that is also an important player. The lipoprotein A, genetically determined, is also an important risk factor. The coronary artery calcium refines the risk, especially if you are in an uncertain region. And the shift towards precision-based cardiovascular risk assessment is what is all this new guideline is about. So let's see why this is important, why these guidelines are important. Because we know that ASCVD remains the leading cause of mortality. There's significant residual risk despite the fact your LDL is normal. You might be seeing a patient of myocardial infarction with a normal LDL of 55. So there is what is called residual risk. The traditional models underestimate the risk. We have new models to find the risk, which definitely gives you correct estimation. The previous one, the model was giving us the either underestimation or overestimation, and therefore we were treating wrongly these patients. Misclassification leads to either undertreatment or overtreatment and need for precision-based risk stratification. So this is what is the first change in the LDL estimation. We used to use Friedewald equation, and this equation, all of you know, is invalid if the triglyceride levels are more than 250. So there was a new change in the estimation of LDL. Use the Martin-Hopkins equation or a Sampson equation. These are two methods which now we use to find out the LDL levels. Either you estimate LDL directly or you want to find out LDL. These are the equations which you use to find out what LDL is. Now let's see the patient 1, patient 2, patient 3. If we look at the LDL levels, all 115. Now you don't know which patient carries a severe risk of ischemic heart disease or a stroke. Now if you look at the next is look at the ApoB. If the ApoB is high, obviously, of course, it carries a risk. Then third is little a, LP, which also is important, which is genetically inherited. That gives you, again, risk. And the calcium score also gives a risk. Suppose all these are put together, you can say that though all patients had the same LDL, but they carry different risk. And therefore, you know that the key risk determinants are ApoB, LP little a, and the coronary calcium scoring. So same LDL doesn't mean the same risk. That's the first important lesson of this particular guideline. So therefore, we know about LDL. So this is what the LDL particles are. So large number of particles obviously gives you more risk. And therefore, two patients with the same LDL level, those who have high number of particles will be atherogenic particle and therefore carries a high risk. And the targets for the ApoB is 90, which is acceptable below. Below 80 is for the high risk and 65 to 70 is for very high risk patient. So when should I do ApoB in my practice? That's the immediate next question that you would have in your mind. So you do it when there is a discordant profile. When you have LDL normal with a high triglyceride, you will ask for ApoB. Diabetes patients and metabolic syndrome patients, yes, you'll ask for it. Patients with obesity and insulin resistance, residual risk despite of controlled LDL. I told you about a patient who had stroke despite the fact that his LDL was 55. You will do for ApoB. And a borderline or indeterminate risk, again, you will ask for a ApoB. So ApoB is again important. After that, the next important is lipoprotein A, which is an inherited risk, which is inherited by autosomal dominant disorder. And if you know that LPA, what is it actually? It actually has a similar core like LDL, very similar, but it has an extra tail, which is called the ApoA tail. And this is the tail which determines the heterogeneity of a drug of the ApoA. And the longer the tail, better is the protection. Shorter the tail, more is the risk of atherosclerosis and thrombosis. What it actually does is that the ApoA resembles the plasminogen. Therefore, it blocks the action of plasminogen. And once you have a clot here, the clot is normally dissolved by the plasminogen, which is converted to plasmin. But this conversion of plasminogen to plasmin is prevented by the ApoA, and therefore the clot progresses. So therefore, we have two problems with LP(a). One, it causes atherosclerosis. Secondly, it causes the thrombosis of the clot. So it's a pro-atherogenic and a pro-thrombotic matter which is responsible for the cardiovascular events. And when you measure, remember there are two kinds of measurement we have, the milligrams and nanomillimole. But remember that nanomillimole is much more reliable. It's a newer kind of the estimation method than the milligram. So when you want to rely on the report, always insist that I would like to have nanomillimole rather than the milligram as a method of estimation. So this is the LPA, which has a very similar to LDL. And this is the tail, which is called the kringle. And this kringle has the homology for plasminogen and therefore blocks the effect of plasminogen. So in 2026 guideline, it says the measure once in all adults identifies the lifelong inherited risk and explains the residual risk in the normal LDL patient. And therefore, as I mentioned, the 125 nanomillimole is much more important than the milligram. Insist on this method of estimation rather than milligram. The risk is continued, there's no safe threshold, and it supports the earlier therapy, more intensive LDL lowering, and sometimes use of calcium scoring for a reclassification. So LPA is a risk you cannot see on the standard lipid panel. Therefore, you have to ask for it in every patient at least once in the lifetime. So the 2018 guideline and 2026 guideline, what is the major focus of the change? The LDL focus has remained there, but here it's only particle based. The equation that we use is the pool cohort equation as a risk finder, which is changed to prevent, and it's only used for threshold. What we had in 2018, we never had the value of the LDL, say 55, 70. It only said reduced by 50%. But now we have target plus reduction. We say we want the LDL to be 55 in a very ill patient, and the same time reduction should be more than 50%. The calcium score was optional in 2018, is central in 2026, and LP(a) was also optional. It is compulsory for all patients to do LP(a). So let's look at these two important, the equation, the pool cohort equation and the prevent risk score. This tells you only about 10 years. It's about 10 years plus 30 years, which is lifetime risk. It depends on change on the age, because if it's an elderly patient, it overestimates, younger patients underestimate. So therefore, this has a problem with the age, but this is very well calibrated and it includes the people of lesser age around 30, but this was around 840. It focused only on the ASCVD, but here it's ASCVD plus heart failure. It had a multiple variables like metabolic factors, BMI and CKD, which is only on lipids and DM and smoking. Derived from the older cohorts with less amount of population. This is updated with the contemporary population. It may overestimate the risk, but this is very accurate. It has a short-term prediction. It's a long-term trajectory assessment. It's a population-based. It's more personalized. So the prevent expands the risk from a static to dynamic personalized assessment. So therefore use prevent score to find out the risk of the patient. So what it tells us, it uses the age from 30 to 17. I told you this younger age group is involved. It is for primary prevention population when there is no established cardiovascular disease. It's used before treatment decision and is not intended for patients with known cardiovascular disease or severe hypercholesterolemia or a family hypercholesterolemia, high-risk patients requiring treatment. So prevent is for uncertainty, not for the obvious disease. If you have a patient with obvious disease, of course, you will not do prevent scoring. It tells you about 10 years and the lifetime, which is 30-year risk. It serves as a starting point, not as a final decision. Hence, the risk must be defined with the ApoB, LP and the calcium scoring, which tells you about the actual disease burden. So number estimates the risk and the biology defines the risk. So this is how you give the answer when you use the prevent. It tells you the risk is low, which is less than 3%. Borderline is 3 to 5%. Intermediate is 5 to less than 10. And a high risk is more than 10%. This is how it gives you the answer when you use the prevent scoring. So the clinical meaning for the prevent score is that the low risk do not assume low biology. The hidden risk may still be there. And a borderline risk, of course, decision zone, which you start treatment in these patients. Intermediate risk, again, the treatment threshold is important. Refinement is strongly recommended. And a high risk, treat regardless of the score. Biology does not delay therapy. So this is exactly what the prevent score is. It tells you about low score when there's only counseling and lifestyle modification. If it is 3 to 5, consider risk enhancers. With intermediate risk, at least moderate statin therapy, and a high risk, of course, the statin therapy. And it also tells you what goal you should achieve. Now let's look at further what is called the coronary artery calcium. It also tells you that intermediate risk, there's a strong indication to do the calcium scoring. In the borderline risk with uncertainty, again, you can do calcium scoring. Discordant risk markers, when the LDL, ApoB, there's a mismatch, you ask for calcium scoring. And a patient who's hesitating to take statin, he's not sure whether he should take statin or not. Then you can use the calcium scoring to take the shared decision support. So the calcium score is used when the decision is uncertain, not when it's very obvious disease. So this is how you get the score 0, and it means that there is no need of statin. But remember, in patients of diabetes, smoking, strong family history, high LPA, you should override this and should treat, because diabetes and smoking can have soft atherosclerosis, which may not have calcium. So the calcium score can be still 0. The important point you should remember when you ask for the calcium score, with 1 to 99, it favors statin, and with more than 100, it's a strong indication for statin. So calcium score converts risk into disease, and the decision drives the treatment. So remember, calcium scoring is a very important factor to decide about statin or no statin. So this is this scoring again, 0, 1 to 99, and even beyond 1,000 also, where you get high intensity treatment and get LDL to as low as possible. So let's look at now the prevent, how to treat these patients of lipids in 2026. First, of course, you estimate the severity, use the prevent score and find out what the risk it is. Then you personalize the risk of this patient, whether it's ApoB, LP and look at the risk enhancers and then reclassify based on the calcium score. And of course, finally, it's treat to target. So therefore, LDL is independent trigger for treatment. If the LDL is more than 190, you don't waste time in scoring. And if LDL more than 160 with risk enhancers, you should consider statin in these patients. At a very high levels of LDL, we don't waste time in calculation. We start treatment in these patients. So these are very risk enhancers. This is a new entry here. We have various biomarkers, which already talked about, the calcium scoring and all that. What is more important is the family history for premature atherosclerotic cardiovascular disease. What it means is the parents having acute event, either stroke or a myocardial infarction before the age of 55 in a male patient and before the age of 60 in a female patient. Patient of chronic kidney disease include at risk enhancer. Patient of metabolic syndrome is included. Chronic inflammatory disease like SLE, rheumatoid arthritis are included as risk enhancers. And don't forget to take reproductive history. The preeclampsia in a lady, or a premature menopause, or a gestational diabetes are all risk enhancers. A proper history taking and a proper analysis is important when you think about lipid therapy in a given patient. So the step one when you treat patients is the foundation therapy, which is lifestyle, risk factors control. Look at the blood pressure, diabetes, and weight. Statin, of course, is the first line therapy. Intensity of the statin is based on the risk. With a moderate risk, you want to reduce the statin by 30 to 49%. If it's a high risk, you reduce the LDL more than 50%. So statin is the foundation. Everything else is built on it. So the LDL targets risk depends upon the intermediate risk. You should take the LDL below 100. If it's a high risk, get LDL below 70. If it's a very high risk, means the patient who has established cardiovascular disease, the risk is the LDL level should go below 55. So lower is better, but the target depends on the risk. The target that you choose depends on what risk the patient has, and based on that, you take the treatment. Now, when you want to intensification of treatment, the step two, the patient not at goal still, you need to add ezetimibe, which decreases your LDL by further 20%. If still not at goal, then you have PCSK9 inhibition, which reduces by 60%, and inclisiran, which is an alternative for the adherence and dosing issue, but it is taken number 3 because there is no guideline to suggest that inclisiran reduces the cardiovascular event. That trial is still pending, but the PCSK9 has the trial evidence of reducing the cardiovascular event. So they escalate based on the response, not by routine method. So the precision approach in lipid management, ApoB guides the residual risk. LP talks about the risk inheritance and more aggressive LDL lowering. And the calcium score guides initiation intensity. Remember, again, I told you the same LDL is not the same risk. So once you have the risk on board, so we have to use the risk-based targets. For intermediate risk, I told you get LDL below 100% milligram percent, and reduction should be more than 30 and less than 49%. In a high-risk patient, get LDL below 70, and reduction must be more than 50%. So this is how you treat both the estimated and the biological risk, and not the LDL alone. The step 2, you have to refine the risk. If uncertainty still remains, you're still uncertain, then take the help of calcium scoring. It guides about initiation and intensification of therapy. Look at the ApoB, if it's more than 100 milligrams, high atherogenic burden, and look at LP more than 125. Again, it tells you about inherited high-risk phenotype. Now we also have the non-HDL target on the board, which was missing in the previous guideline. And this is about 30 points higher than the HDL. If the HDL is 55, it is 85. If it's 70, it is 100. If it's 70, it's 100. And if it is 100, it is 130. So therefore, we now also have non-HDL target again, which was missing in the previous guideline. And the advantage of non-HDL is that you can do it anytime blood. All that you need is HDL and total cholesterol. You minus HDL from total cholesterol. All remaining lipids are the atherogenic. So it has the level 1 evidence to use this as a non-HDL cholesterol in a given patient when you're treating lipids in these patients. The secondary prevention strategy is also important. And what are secondary patients who have already had atherosclerotic cardiovascular events, or one who have more than 2 risk conditions like age of 65, had history of revascularization, smoker, diabetes, heart failure. And therefore, these patients, of course, you get the LDL at a high risk of 70 and very high below 55, and you require the high intensity statins. The class of recommendation is 1, ezetimibe, bempedoic acid, and inclisiran. So treat early, treat aggressively, and treat to target is for the secondary prevention. Secondary, of course, you have to treat as early as possible. The special population that requires mention is the chronic kidney disease. In the past, this was also again missing. because people felt those who have chronic kidney disease do not die of atherosclerosis, they die of heart failure because increased hypertension, the atherosclerosis levels off after the stage 2A of kidney disease. But now this guideline is included, the stage 3 as plus guideline is included to treat statin therapy. And here, of course, there's the class of recommendations. One, moderate statins. Ezetimibe is also given. Only in dialysis patients, initial statin is not proven beneficial. Continue patient already taking on it. Diabetes, of course, any diabetic patients 40 to 75 years without any history of ASCVD require statin therapy. The moderate intensity statin therapy and get the LDL below 100. If there's a high intensity statin, if there's a multiple risk factors, get below 70 and consider eicosapentaen ethyl if the triglyceride levels are more than 150 and statin intolerance, ezetimibe, bempedoic acid and PCSK9 monoclonal antibody can be used. And of course, patients living with HIV and hypercholesterolemia also are included in a special population. The triglyceride treatment also has undergone a lot of changes. Of course, we have a drug which was in the past was used. We use fenofibrate, which is used. And now we have new drugs which have come in the treatment arena. The olezarsen is also US FDA approved. It's a subcutaneous injection therapy, which is the ApoC3 inhibitor. It is available, in India, but of course, under special request. Fibrates are also used, omega-3 for a pancreatitis risk, and urgent lipid specialist referral and a dietitian referral also important. So the evolving concept in lipid management is the early combo therapy, do not delay adding ezetimibe. Treatment is proactive, not reactive. Risk is continuous, not just categories. Escalate based on the response and total risk, and the modern lipid management integrate risk, biology, and early intervention. So what's new, what we have seen today in the highlight, is the risk assessment, the prevent. It talks about CPR, which means to calculate, personalize, and reclassify the patient disease and treat intelligently. Treatment goals have changed to 55 LDL in the high-risk patients and a non-HDL to below 85. The special population we discussed, the HIV, the cancer survivors, the reproductive risk markers are also new risk enhancers. The lipid testing Lp(a) is again mandatory for all patients at least once in lifetime. ApoB is useful when LDL is at goal. And the Martin, Hopkins, and Sampson are the methods to estimate LDL, but not the Friedwald. And new medication like olezarsen, which is ApoC3 inhibitors, is FDA approved. Inclisiran is added as second line, though it is the evidence is only 2A because there is no trial evidence to show the cardiovascular superiority. Bempedoic acid is endorsed with CV outward evidence with a clear study shows that the bempedoic acid has the CVOT data. The supplementation of diet, for example, dietary supplements are not recommended for the LDL lowering or triglyceride lowering. Dietary supplements include fish oil, red yeast, rice, cinnamon, turmeric, garlic. I think there is no evidence for that, so it's not recommended. So the carry-home message is 10 top carry-home message. This is exactly what is there in the guideline. I've just copied that. Start lifestyle counseling in youth. Pharmacotherapy for familial hypercholesterolemia if the LDL more than 168. Lower threshold for lipid therapy means consider lipid therapy at the 3% to 5% borderline risk. Recommend at 5% to 10% intermediate risk. ApoB is very important to estimate and use prevent equation. And LDL goals are back again now because in the previous guideline, there's only percentage reduction, but there are no goals. Now we have goals for LDL. Measure Lp(a) at least once in lifetime, and more than 125 is an important risk factor. Statins in special groups, especially diabetes, chronic kidney disease, HIV, regardless of the LDL level. Statin is the first therapy for triglyceridemia. Remember, that's important that you use first statins, and then if the triglyceride levels above, then you treat with other drugs. Calcium scoring does matter. So it's important for more than 40 years in men and 45 in women to reclassify and guide the LDL therapy. Secondary prevention goal is LDL below 55 and non-HDL below 85 in every high-risk patient. And point number 10, we do no longer treat LDL alone, we treat overall cardiovascular risk. I think with that, I finish my talk here. Thank you very much for the patient listening. I stop sharing.